Thank you everyone for being back at Revolutionizing Healthcare. We have a very important announcement to start off with. You've probably already heard of this, but it's really important for us to stress this. We're running the Cambridge AI in Medicine Summer School this summer, and it's targeted especially and specifically to clinicians and also medical students who have very limited or no machine learning expertise. And the summer school is really going to give you all the fundamentals you need to get started. And what is really amazing about this is that you'll actually be able to use machine learning hands-on, and more information on that will follow very soon on all our socials as well. Without further ado, let's get to the session. Today, we're talking about machine learning in cardiology, and this is, first of all, a field that is really ripe for machine learning because it has a lot of data. And also the Schaar Lab has done some of its best work actually in this area, which is highlighted on our newest blog post, which you can view on the website. We're really happy today to be joined by two amazing guests. First of all, Professor Fonarow, and secondly, Professor Asselbergs, who Tim will introduce in just a minute. And of course, leading these sessions is Mihaela van der Schaar, professor at Cambridge for AI, machine learning, and medicine.
Thank you, Tim.
Tim, over to you.
Welcome, everyone. Let me first introduce our excellent panel with first Professor Gregg Fonarow, who is the Elliott Cordy Professor of Cardiovascular Medicine and Science at UCLA. He also serves as interim chief of UCLA's Division of Cardiology and is director of the Amundsen UCLA Cardiomyopathy Center. With over 14,000 published studies, Dr. Fonarow is a leading expert in heart failure management and preventative cardiology. Thank you for joining us. Our second panelist is Professor Folkert Asselbergs, who is the vice chair of the Amsterdam Heart Center and also professor of precision medicine at both University of Amsterdam and UCL. His research focused on precision medicine as well and cardiovascular genetics, and he has published numerous scientific papers as well. Professor Asselbergs is also the director of the PRC Clinical Research Informatics Unit. Thank you both for joining us today.
Thanks, Tim. And now if we go to the next slide, we just want to quickly explain how this session today will work. It's roughly 1 hour as usual. And after the introduction, we will have 3 presentations by Professor Fonarow, Professor Asselbergs, and Professor van der Schaar. And then we'll have a lot of time also for discussion among the panel, but also with you, because we'll have Q&As and you can ask questions throughout the session in the Q&A chat. And you can also upvote the most important queries there to tell us which questions we should address first. So without further ado, I would really like to hand over to Professor Fonarow to get us started. Thank you.
Great. Well, it's a pleasure to be here, and I'm actually going to go without slides. I'm going to share my perspective on really what are some of the greatest opportunities for AI and machine learning for cardiology. Share this perspective with having been actively involved in quality of care and outcomes research, implementation science, as well as clinically heavily involved with heart failure. My background also, though, involves with, having served as clinical co-chief and interim chief of the UCLA Division of Cardiology. We have 125 cardiologists on faculty. UCLA covers close to 800,000 lives. So we've been very invested in the delivery of cardiovascular care, and that also shapes my perspective. If we look at where the opportunities are, they're really tremendous. We have all of these phenomenal advances allowing us to identify individuals at risk for cardiovascular disease, have incredibly effective preventative therapies that could be applied to those individuals, as well as those who have had acute cardiovascular events, survive them, now have chronic cardiovascular disease, where we have number of therapies that can markedly improve their outcomes, prevent recurrent events. Those with heart failure help restore their heart function, avoid progression. But if we look at in almost every setting, there are these tremendous gaps that exist. Large number of individuals that are at risk for cardiovascular disease, but are not fully aware of that. Their clinicians don't necessarily have complete access to that information, and optimal preventable therapies are not being applied. Their cardiovascular risk factors are not being controlled. We have a large number of patients that are undergoing active cardiovascular care, are getting different cardiodiagnostic studies, things as routine as EKGs or more advanced imaging, PET scanning, cardiac MRIs, echocardiography, but yet information that's available from that testing is not necessarily fully recognized and integrated in their management. We have a large number of patients that are ongoing care where we're prescribing medications without realizing in many cases the patient is not adherent to that therapy, going on year after year, getting it potentially high risk, and then coming back in with acute events that we're now treating or escalating care. So with regards to these really large unmet needs that we have, there's tremendous opportunity. The one other thing I will highlight, we have these phenomenally well-trained faculty that, interact with patients and share their expertise, but so much of their time is now in the sink of having to interact with electronic health record and provide all of this tremendous documentation. And so we have tremendous time and efficiency to where clinicians are doing a whole lot of data entry and busy work. And this ends up being very inefficient, incredibly expensive, and interfering with what our ultimate goals are. So with that backdrop, I think there are a tremendous number of opportunities, some of which I've been personally involved with, and others that AI and machine learning could help phenomenally with all of these factors. So with regards to identifying individuals at risk, we use the pooled cohort equation, SCORE, Framingham risk scores to identify who's at risk for atherosclerotic cardiovascular disease. And at best, those C statistics sit around for discrimination at 0.7. And, that's not necessarily completely actionable for applying preventative therapy. And there are numerous examples now of using additional information from machine learning AI, developing enhanced risk scores that have far greater precision. Another example where AI can be helpful, and this is an evolving area, which is it's been recognized there's data from the EKG that, highly trained readers don't necessarily pick up upon that can improve the criterion diagnosis, but can go beyond that to where detecting individuals that don't yet have any heart failure symptoms, but have asymptomatic left ventricular dysfunction, or at dramatically higher risk for developing new onset clinical heart failure and much higher risk for mortality, that using AI algorithms on the standard 12-lead EKG can identify those individuals with good calibration and good sensitivity and specificity. And so you can imagine, and these trials are now ongoing, we're taking that information on the routinely collected EKG, could identify individuals at higher risk for having asymptomatic LV dysfunction, trigger additional testing, biomarker, echocardiography, identify those individuals that truly have this from the signal from AI, getting them then on medical therapy that can block progression onto symptomatic heart failure and markedly improve clinical outcome. So there's an example, taking AI enhanced knowledge, applying it clinically to potentially then improve care and clinical outcomes. We have tremendous information that comes in from cardiodiagnostic scans that may not be directly for cardiac imaging, but any thoracic imaging going on where you can detect coronary calcium that's not commonly looked at in the radiology report or reported out. You can use AI to automate this, trigger alerts to the clinicians as patients at increased risk, has subclinical atherosclerotic cardiovascular disease, should be at statins, and can apply this therapy. And then along the lines of clinical delivery, we could have AI accompanying each visit with the patient, be recording that, entering an electronic health record, and in a brief interaction from the clinician, make a visit and its documentation so much more efficient, so much patient-centered, where the clinician's time is face-to-face with the patient and not buried in the computer, providing a higher level of documentation and ultimately make the same level of care better from the patient standpoint and more efficient. And then one area that I really think I want to highlight and would charge everyone with thinking creatively, and this is an area really have not seen much work begin on, but I think is critically important. We've seen in data after data that key determinant of clinical outcome of our patients who have already presented with disease is whether or not they are adherent to their medical therapy, whether they're persistent to the medical therapy. With our current approach to managing these patients, we don't detect that, don't manage it in a proactive way, and it is a major contributor to events, recurrent cardiovascular events, individuals getting hospitalized with heart failure. It drives so much of the cost of chronic cardiovascular disease. So we're talking hundreds of billions of dollars of costs that are all related to non-adherence. And right now we just depend on, we ask the patient, are you taking your medications? They say yes, and that's the end of the story. Or 3 months after a pharmacy detects there were no refills that were refilled, you may get, this letter sent to you by paper mail. So if we could utilize all of the signal and channels that AI could monitor, enhance, and provide closer to real-time feedback to clinicians, to patients themselves, to their families, to the healthcare delivery system in a way that could enhance adherence, that could have phenomenal impact on the value proposition of care that we provide, on the actual clinical care, and most importantly, dramatically improve, clinical outcomes. So from my perspective, there's tremendous opportunities here. There's a large amount of work going on. We're still in the infancy for all the things that I've talked about. We haven't yet fully demonstrated, okay, AI was applied and we actually improve clinical outcome. There's some hints from some studies, but there's the opportunity to enhance the approaches, fully tested in prospective randomized trials, as well as observationally, and demonstrate, the full potential of this, technological revolution. So those are my, initial thoughts, and happy to answer any questions that come up in the discussion, as well as further clarify some of these thoughts. So thanks so much.
Wonderful. Thank you for that introduction. And also, I think it's really interesting that you highlighted adherence. I think we should definitely come back to that later. So now I would like to hand over to Professor Asselbergs.
So thanks. Nice to see that the views of Gregg are nicely overlapping with mine. So this is the question that we are going to address today. So what will be the greatest impact in cardiology, the challenges and opportunities of ML and AI in cardiology? And from my perspective, but I'll explain a bit more in detail in the slides that we have that I put together. Automation, right? It sounds boring, especially for researchers, but it's really critical for us as healthcare professionals, because we're doing a lot of boring stuff there, a lot of repetitive measures and repetitive, as Gregg mentioned as well, 50% of our time we spend on admin, right? Epic is our worst nightmare. We cannot do without, but we're bound to it. But automation is key. So even though maybe for scientists or knowledge discovery is much more sexier, automation is key, right? And it's low-hanging fruit, if I'm honest. But I'll show you some examples later on. Democratization of data and knowledge, I think, don't underestimate that if you're a patient and sitting in front of a doctor, right, which is still predominantly male, gray, white, there's a distance. right? There's a distance between us, right? There is an information gap, there's a knowledge gap that we can bridge, right? If we have the democratization of data, that people can own their own data using AI and then map guidelines, map the knowledge that's generated by us as a community, there's a different playing field, right? People will come in much more informed, and that will radicalize healthcare, right? Of course, it will be different, the conversation. Early detection, I think AI will play maybe later, but not a big role yet in really complex care, right? Multimodal is still difficult, right? Single source is fine, multimodal is difficult. That will take time. So I think early detection, prevention, I think AI can play a big role, especially if it's not seen by the human eye. We're of course limited by our brains, right? And by our education, where we can look at an ECG or an MRI, but we don't look at pixels, right? And we don't look at 0 and 1s. And that's something, especially for early detection, quite key. And as Gregg already mentioned, guideline adherence, right? So how can we, I think, again, right, as a research, we're of course more interested in finding new things, but we know a lot and we still don't do it, right? So there's an implementation gap. Again, it's really not really exciting if you're young, but it's key, right? That we actually do what we know. So these are the 4 points, and I just as an illustration, right? So I think this, for example, echo, right? Imaging echo is like next to the ECG is the workhorse of the cardiology, and of course AI can interpret echoes in a similar quality as experienced sonographers, but it can also perform. And I think the last one is more exciting. So I'm doing research myself in Tanzania, where they don't have all the expertise and the capacity, but you have now this handheld echoes who don't only analyze the images, but they also say how you make the images. So you put the transducer on the chest, and the AI will say, okay, you have to go up, you have to go to the left and the right to do the acquisition. And that really will change, right, medicine. So I think cardiologists will still what cardiologists do, but I think a lot of our work will move to primary care, will move into the population, right? ECGs can be read by everyone. Echoes can be made by everyone. So the bulk of cardiology will move towards the first line of healthcare and not to the cardiologist per se. So I think this is quite innovative. The same applies for ECGs. It's just, there are a lot of other things already on ECGs. There's a lot of work, as Gregg mentioned, so this is not limited by. But just realize you can take a picture now of an ECG, also in low-income countries. It will put it in digital waveforms automatically, and you can put an XBoost or a factor analysis towards it, and it's better than the human eye. Maybe not the most experienced cardiologist, but in primary care, in local settings, it can really help you distinguish pathology for referral. So this really will change the way we do medicine and the burden for the cardiology community. LLMs, of course, I won't go into detail because it's like a topic what you do like every time during this session. But of course, it's next to just drafting like discharge summaries. It's also chatbotting for informed consent, for example, in clinical trials, which you spend a lot of money and a lot of time on, can be replaced. Of course, it can help with guideline adherence. But also you have to realize, I'm not sure for Gregg's department, but in Amsterdam, but also at UCL in London, we don't write letters to patients. It's quite remarkable. If you go to a doctor, you don't get a letter. So you don't know what you're having, and you don't get any correspondence. We correspond to each other peer to peer. And I think LMs are really nice to correspond directly to patients and have an interaction. And I made an avatar, I won't show it now, but I have an avatar of myself, which can explain more in detail to patients when they're home about statins, for example, or prescription drugs or their disease, more in general terms. And I think, again, maybe not really exciting, no Nobel Prize, but really important on a day-to-day basis. And of course, LM is one part, but foundation models will, of course, change how we are going to practice in the near future. So, of course, it's about trustworthiness, I think, and hopefully with Mihaela and Gregg, we can have this discussion later on. Because I think that's key. I think it's not the technology, it's there, right? I think what limits us, of course, accessibility, interoperability of data, but also the implementation and the trustworthiness, right? And I think trustworthiness can help. So we're building now ourselves LLMs of EEC guidelines that we can easily implement on our electronic health records to see, okay, as a ground truth. And maybe it's not, right? We don't know everything, so we'll give answers, okay, we don't know. But if we do know, then we know it's based on the guidelines, it's true. Of course, I think it's really key to get to the next phase of implementation. This is what Gregg mentioned as well. We need trials, right? It's really remarkable that we have drug trials, and we do it for decades now, and we don't have clinical trial units for AI, and we don't have a platform. It's another topic of discussion maybe later on. We need like platform trials where we can easily evaluate algorithms, right, across our clinical healthcare settings in a cost-effective manner. We don't have 5 years time as we have in drug. Of course, the field's moving too fast, and we're not protected always by patents. But now we have only 5 clinical trials in cardiology published. I know there are much more now in the pipeline, but still, it's limited. And we need to think about different trial designs, but that's something also for the discussion. Like I always use the New York Times, booking.com, that they're continuously randomizing people to algorithms, right? That you buy stuff or book a room. We can do the same for healthcare, but we need some surrogate outcomes, how we can evaluate the success of an algorithm implemented in daily care. So this is just to mention, it's on the website. We have this big consortium across Europe for AI for heart failure. It's about trustworthiness, where we do, according to the future AI guidelines, where we try to develop the AI algorithms in heart failure, but not instead of, okay, we have an algorithm, we just implement it and say, okay, what do you think? But really, what are the requirements from a patient, payers, clinical, societal perspective, what are the requirements for it? And we're building an AI passport to make it transparent and providing some kind of white paper at the end, what we think as a professional society that algorithms should adhere to. So it will be published soon, but it's already website is live. And of course, education, but that's something that you do today already. And in the summer school, they just saw as well. We need to educate, not the future only, right? Because I think in the master programs, everybody knows it now, right? We have to educate people, but there's a workforce today that we have to educate as well. And it starts off, how do you review papers, right? I'm editor of European Heart Journal for AI, right? How do you review papers? What are the quality criteria, right? There's a lot of rubbish out there. Just for your awareness, I just edited 200 papers and accepted 4 in the last 2 years. It's really, there's a lot of unknowns there. So we need to educate our workforce. So I'm looking forward to the discussion. Hopefully this will help guide it.
Wonderful. Thank you so much for that as well. And I would like now just give Professor van der Schaar the opportunity to also highlight a couple of things from the ML side.
Thank you so much, Gregg and Folkert. Such a wonderful opportunity to have the chance to discuss with you. And like Gregg, I'm deciding not to have slides, but rather more or less make notes during your wonderful presentations and try to link back to my own experience as a machine learner trying to build technology under the leadership of a variety of cardiologists in various countries that I collaborate with. And first, I want to start with this idea of risk, because it's to some extent the first, let's say, the easiest to start with AI is to get involved with risk and try to really move from a population risk like Framingham models to more personalized risk, and really try to understand what different classes of patients may need to, what type of information may be needed to acquire for these different classes of patients. And at least in my own past work, we were able to show that, for instance, diabetics versus non-diabetics, women versus male, if you want to really improve significantly performance for different classes of patients, you may need to include additional variables than the Framingham score and potentially nonlinear interactions. So I'd be quite keen to hear from you about that. So that's the first one, risk. The two of you didn't talk about it, but often I think, especially in elderly, there is this issue of competing risk. And in our own research, together with collaborators, we looked often at competing risks, especially for elderly and especially in scenarios where there may be medication involved. So where AI potentially could also help, and I'd be keen to hear your thoughts, is the idea of competing risks. Then moving to early diagnosis, and I was very excited about the fact that Gregg talked about it, and also you, Folkert. The question is really, often we have observational data from patients who may come originally to the clinicians with particular type of symptoms, but often potentially the patient may come for the first time when they have experienced that particular cardiovascular event. So the question is, can we really use other sources of data, whether this data is outside the clinical domain, but potentially based on wearables, based on other sources of information? And I'll be quite keen to hear your thoughts about that. Then moving maybe even further down the line, actions and treatment. We ourselves do a lot of work in the lab where we look at causal machine learning, causal effect inference, trying to use either clinical trial data or observational data, such as electronic health records, to identify what treatment would be best for what type of individual and when. So I'd be quite keen to hear your thoughts about that, about treatments, but also alternatives between treatments, and even something else, which is dose. Because this is really an area where if there is variation in practice, and I think in cardiovascular disease, that despite the existence of guidelines, there is variation. There is an opportunity also for us to use machine learning to learn from this variation, to really understand how to best either give treatment or even switch treatments for patients. I'd be keen to hear some more from you about that. So sorry, I make a long list and you can decide what you'd like to pick. About both early diagnosis and as well as treatment, and also related to supporting clinicians, the question that often is overlooked is, when should this patient come back to see you? And I would be quite keen to hear from you. We discussed in a different disease, in cancer, about the fact that a more personalized monitoring of patients would be beneficial. So not everybody should come back after the same amount of time, but determining when exactly this patient should come back, given their trajectory of disease, could maybe save lives and save clinician time. So really trying to understand when the person should come back. Another interesting point, I think that was made there, and I think this point was made by Gregg, was about the value of information, really. Do you really need to have genetic testing? Do you need to have a particular type of imaging? What type of imaging to be able to give the right diagnosis? So really even understanding the triaging process such that you expedite either diagnosis or treatment. Could AI help by looking at the vast set of tests that are at times given to patients to really understand what's the most valuable test given the current condition and given the projected trajectory of the patient? Then just finally on this issue of adherence. So I think it's interesting. It's on one hand, patients adhering to medication. On the other hand, is clinicians adhering to clinical guidelines. And as we know, these clinical guidelines at times may not provide the right flexibility to the clinician to take into consideration the unique characteristics of the patient. So clinicians may adhere to guidelines or may deviate from guidelines depending on the evidence in front of them. I think that machine learning actually can do a tremendous amount to understand whether patients have adhered to medication, and also can help for alerts identifying that the patient may need additional support. But there is also the idea of variation in practice among clinicians that we discussed in past sessions, especially with hospitalists. where the discussion was that there is a lot of variation in how they practice, and hence there is an opportunity to learn from each other about better practices, and ML can help learn from this variation in practice to propose guidelines that maybe are making more sense than current guidelines. So can ML speed up formation of new guidelines, adaptation, and personalization? I'd be keen as well. And final, based on data, I'd be also interested to hear, Folkert, you mentioned the whole data. In order to be able to do ML, we need data. A lot of data exists, but often is real-world data. So it is messy, it is erroneous, has all sorts of biases built in. It's often not harmonized. And you cannot easily transfer knowledge, let's say, from Amsterdam to UCLA. So the populations are different, but also the data sets may be somewhat different, and the medications and the codes at times may be vary. So the question is, can ML help with that? And I think that this is possible. We have shown similar examples, but not in cardiovascular disease, but I'd be curious, what are your thoughts on that? So sorry, many things inspired by you. Feel free to answer only some of them. This is actually a question to you, Gregg, and to you, Folkert. What do you feel that AI could do in these different cases, and what are your thoughts on that? And do you have homeworks for us? So our sessions are also watched later by quite a lot of AI researchers interested in healthcare. So if you want to give us good problems that you think especially we need to solve, we are keen to hear that as well.
Gregg, you want to kick off? It's just in this
Sure.
laundry list.
I'll pick up on one of the areas that we've spent a lot of time with, which is this issue you raised with regards to, okay, so we have these randomized clinical trials, we have these guidelines, and then we actually look at how they're applied, and there's this phenomenal variation, incomplete application, takes 17 years from the definitive clinical trial evidence till we get 85% of patients treated, and they're treated with a bunch of random doses. And we showed, in CHAMP-HF that, just for triple therapy at target dose, it was less than 1% of eligible patients. And you'd say, this is crazy and what's going on here. When we look into it, is this just being highly personalized in care? So much of it is just misperception by clinicians, where the underlying condition or comorbid conditions has its set of symptoms, but they're misattributed to medications. We've shown in the randomized clinical trials on placebo, you get a whole host of side effects that are identical to the medications, and you can't distinguish between the placebo rates and the medication rates, but yet clinicians attribute all of the time, as do patients, side effects to the medications. We've seen with performance improvement programs that just putting them into place, you double or triple the use of a medication, that proves that it wasn't, this variation is really being customized, especially when the improved use led to better clinical outcomes. So we do think AI can assist with this in this clinician of trying to discern what is external noise, what is, the related conditions versus getting on medications. We have a whole host of misinformation, a little bump in creatinine, and thus a cardiac and renal protective drug get discontinued or lower dose by the clinician, which completely wrong direction to do and works for adverse outcomes. So I think there will be smarter learning for individual patients and populations that can assist clinicians, assist patients through this to better navigate their initiation and up titration and then maintenance of medical therapies in a way that will markedly improve clinical outcome. And then importantly, monitor those patients where the whole system is working against them, that, they 30-day follow-up for their medication, it's not triggered again. And some of those things just lead to fatigue in the patient, then doesn't renew, where this would immediately detect it, trigger all of the algorithms to ensure that patient, gets back on the medication there's an absolute contraindication. So there's a tremendous amount there that I think can be done. I'm more skeptical that we can do these N-of-1 trials and personalize specific dosing, so long as well tolerated for that patient, because I think a lot of these heterogeneity in treatment effectiveness and responses are, hallucinations due to low power. And so I'm more, skeptical on that aspect, but there may be with more precise markers of response that then if we get to that level of knowledge, then we'll be able to more customize those medical regimens at the personal level, as opposed to taking a population health benefit and applying that.
If you allow me to jump just briefly in, Folkert, before, so Gregg, so what I envision that kind of, I think, supports what you are saying, but goes in a slightly different direction, is to use not necessarily only clinical trials, but also to use observational data like the electronic health records, where a lot of experiments are done by clinicians in the diverse clinics of the world, and use this biased observational data together with machine learning, causal machine learning, to try really to identify this variation in response to treatment, response in dose, response in the timing at which maybe the medication or the intervention was attributed. And the reason I think that that may be an advantage to some of these other ways of thinking about trials is we have the sheer amount of data that enables a lot of we have diverse populations and also large sample size. So we have tried to do some of that in a particular type of cardiovascular disease trial, and we are able to show that actually effects of treatment can be much better estimated than in the trial. And this is unsurprising because of the large number of populations we have and the diversity of that. So just a brief follow-up before Folkert responds. Do you think that electronic health records and potentially these causal machine learning methods that estimate effects of treatments and heterogeneity of effects of treatment could be a way to support what you are saying?
So my take currently, and of course it could change, is no. I actually feel pretty strongly about that so much of this is going to still be confounding. But I think there's a tremendous opportunity of looking at those patterns of care and understand those gaps and better strategies for implementation, up titration, and persistence of medication. It's so striking. If you start a medication in the hospital, the adherence rate is 3 to 5-fold higher than that same medication started by the same clinician in the outpatient setting. I mean, biologically, that makes no sense, but psychologically, it makes a lot of sense. So I think there's a lot of opportunities there from using these type of approaches, but it's going to be from those patterns of delivery to improve the use and dosing and persistence of the medication, more so than saying, oh, this patient doesn't need an SGLT2 inhibitor, even though they've got heart failure with reduced EF, because we really, biologically, it just doesn't make a lot of sense when you've got something that's altering the disease state and process and the complexity of the disease that, oh, there's some that it really works for and doesn't work at all for others, in my estimation, with these therapies. With targeted cancer therapy, totally different. And there may be, targeted therapies, and we're starting to see it for cardiac amyloid, to where those type of approaches may help. But I think the large complex diseases we're currently treating, AS, CVD, heart failure, I'm more skeptical about, oh, we're going to get to personalize those meds based on observational data applied with machine learning.
Thanks a lot. Folkert.
No, yeah, it's a great discussion. Of course, you have clearly two camps, right, in literature as well regarding this. So I'm a bit in between. So I do think showing the efficacy with observational data, I think I'm a bit skeptical as well, but heterogeneity in that efficacy, right, that's something that you can do, I think, with observational data, right? So if you have some effect and see whether it differs across different groups, I think observational data can guide you. What is still a bit of missing in the discussion, and it's a bit of on your first remark regarding risk prediction. Of course, we can expand to like trillion features, but at the end, right, often it's age-driven, right? It's only, right, just, I think we have to be transparent what drives, right, a prediction, because often it's only a few, right, markers. So I think that's more common. And what I do miss is that we try to, right, force in features in like a framing of risk model, while you just want to have a risk model based on what's available of that patient, right? So people have data. So what's the risk based on that data? And what I would like to see as a clinician is, okay, the risk is this, but your confidence intervals are that wide, and you can do a BNP or troponin or whatever to be more sure. Or you think, okay, this is just so out of right range or a priori low or high that it doesn't matter whatever you do. So I think it should be a different way of risk prediction.
I am delighted, Folkert, you say that, because we have built an AI method that is capable to do that. So it seems like I need to knock at your door to really try to see if that would be useful in practice.
That would be perfect, right? Just based on literature. And I think, yeah, what we're working on is like on a digital twinning, so that we have a reference data set with synthetic data, so that you can just use that synthetic data as augmented, of course, for your risk prediction, and that you can provide indeed some kind of measures. Okay, you add cholesterol, what happens, right? So to your risk model. And I think we're experimenting. I'm still a bit of right, fixed on the discussion we just had with maybe with MR and genetic risk models, right? To see whether you can do some causal ML as well, incorporating the genetic information. So, but I think and the other thing is what you said as well, when I'm triggered, what I would like to respond on is the other source of data, and you follow up. I think that's the same question. So I think in my outpatient clinic, I don't see any control. I don't see patients for checkups. Of course, if they're okay, we have a great conversation. I can get my reimbursement, everybody happy, but it's just useless. If people have complaints, they don't have complaints at the day that they see me, right? So I'm more like in continuous follow-up based on wearables or some kind. Of course, there are exceptions, right? Of course, with certain valve disease, etc., there are some fixed follow-up time points needed. But for the majority, you don't need it, right? It's just, you can just let it go and say, okay, you're always welcome. And I believe with the PPGs, right, with the smartwatches and the wearables, PPGs, of course, can do the AF detection, but now we're working as well with Apple, and others are doing that as well, to see whether you can also see progression of structural heart disease based on the PPG signal, right? And I see like a multi-step approach. You start up with like complaint or with PPG signal, and maybe then you add on a wearable, for example, and maybe you go to your community service center for a point of care echo, whatever, and then at the end, cardiologists will come. But now the cardiologist is the first line of defense, let's put it that way. And I think that's a waste of resources, and I think that will change.
Yeah, and I just add, Folkert, what ties this together nicely is this idea of dynamic risk assessment, right? So rather than the snapshot and, oh, here's your 10-year or lifetime risk, it's constantly being updated and evolved, including what treatments you take, right? So you go on your statin, you're adherent, it will show that risk being lower back to the patient, clinician, health system. Stop taking it, that risk goes up. And so you can integrate all of this data in a dynamic way that's reinforcing for the patient, but also puts, these signals in perspective. The risk of a 60 or 70-year-old's going to be much higher for a given signal than a 20-year-old, and can make that dynamic to where then follow-up really becomes you're always being actively managed and interacting with the data and getting feedback, and can trigger follow-up when needed, rather than, as you described, does it really make sense to see this individual back every 3 or 6 months when the risk may be dynamic?
So I totally agree, Greg, it has to be dynamic, but also what are the potential effect of certain like interventions that you can mimic it with the digital twinning, but also should we make a CT and then we build like a synthetic CT based on the ECG, and what's the likelihood that you find something on the CT, right? And then you can discuss with your patient, is it worth it, right? To refer you for additional imaging. And I think that's a bit of, it's more dynamic.
That is to some extent about trajectories of disease, which is very much something that machine learning is doing. The moment you do digital twinning, you are starting also to think about some form of counterfactual estimation, because you don't know for sure always what that particular response to an intervention may be. But I would love to continue to talk to you, but I want to let the two teams to start sharing the session and get questions from the audience. So teams, thank you so much, Gregg and Folkert.
Thank you all. I would have just a really quick follow-up question that came up for me in the process. When you talked about early diagnosis and like the value of information, I had a question, and the question is basically, could we measure the value of information by how much the error bounds, for example, when we estimate treatment effects are being reduced by that additional test, for example? Would that be a good measurement of like the how much the test helped?
Yeah, that would be helpful if there's some kind of interaction showing the additional effect of treatments, right? And not only a single treatment, but also the add-on. And also, yeah, as Mihaela said as well, you want to show the disease trajectory. Of course, you get competing risk as well. If one risk goes down, something else may go up, right? And I think that's a bit of where you want to look towards, right? I often have, Gregg, as well, with discussion with like for ICD treatment, right? For example, right? You're going to save your life. And of course, it's really helpful if you're young. But if you're at an elderly age, you get something in return. And you have to show it, right? I think you have to have an information.
These are the competing risks I was talking about to some extent, because I think that I think this will be the excitement of using AI for this longitudinal dynamic risk prediction, where as one ages, the more intervention.
Along those lines, Tim, to your question, it can be very informative to see the different scenarios of the tests that you're contemplating, whether it's really going to change management in a way that could change outcome, and getting feedback from a value proposition. Should I order this $2,000 test if it's not going to really change their care or outcome? And I know that up front, it may modify my behavior in discussion with the patient to not order it, or there's an alternative that would be far more actionable, or an alert. This patient just had the same test, at another center across town and not aware of it, and it's going to get repeated. So there's a lot of, value and utilization that AI machine learning could help.
Yeah, and also just to jump in on that point, because we're also talking a lot about automation, we have a good question from the chat, and I will ask Vinit Osmani to please unmute himself, and you can ask your question live to one of our panelists.
Hi, great, really great discussion, fascinating actually. But I'm just wondering, given the power of these technologies, how much is the risk for automation? What was the question?
Your question was
complacency.
Yeah, complacency.
And especially since you mentioned several times that, clinicians are, and we know that clinicians are overburdened. So, how much is the risk that we trust these systems, almost blindly?
Yeah, it's a great question. So there are some literature in the last few months in the radiology space, right, that they randomized towards AI-assisted, right, analysis of MRIs, and they randomized to wrongly AI, right, decisions, right. So, and you can clearly see that radiologists will follow, even though it's an erroneous support system. So I think it's like, I always compare it with the Google Maps, right, in your car, right? You know how to drive and it says left, and you know it's straight, and you're still going left, right? So I think that's really something that we have to be careful about. But maybe we have to get a virtual agent that checks the AI.
Almost like Folkert, almost like pilots. Pilots are doing all sorts of trainings with and without Copilot. Maybe the same thing will need to happen for all of us who are using AI.
Yeah, though I'm going to add, we have so much of this already going on. There are so many electronic health records that were cut and paste notes where there are phenomenal errors, where a cardiodiagnostic test is done and never gets communicated to the patient, or something major is completely overlooked or missed in a reading. And, on the adherence standpoint, I think all my patients are taking these meds and I have no idea that, none of the prescriptions were refilled until they pop into the hospital with a horrible acute heart failure exacerbation or a stroke, cardioembolic stroke or otherwise. So there's a lot of, misinformation we're living with now with a false sense of complacency.
So perhaps there is a lesson to be learned before we move on to these very powerful technologies. Thank you.
If you allow me to jump in, since Gregg, both you and Folkert talk a lot about complacency, do you think that we have the right data to really look at adherence? And what would be the right data to really use machine learning to estimate that?
Just have a quick response. We don't have the right data. We don't have outcome, right? We have a lot of electronic health record data, but we don't have the data across the different hospitals, across the different parts of healthcare, primary care, secondary care. We don't know what happens at home, right? Sometimes we have links to national registries, mortality, but it's really like, yeah, these are messy phenotypes. We don't know quality, right, of life. It's not, right, it's not standardized across, so it's really messy, right? Within the hospital, it's fine. With the outside linkage, it's terrible. So if you want to solve something,
maybe ML for data harmonization, which is
so that was my. So you put it.
Our lab is actually working on. So this will be music to my ears, to some of my students.
All right. So for your homework, you said, yeah, what kind of homework can we give? And I wrote down here harmonization, harmonization, harmonization. Right?
Wonderful.
Right, help us to automate that we can just compare apples to apples instead to apples to oranges.
And indeed, I think AI can do a lot in this with the messy data. And I'm happy to hear that both you and Gregg believe that actually AI will be more useful for the plumbing of medicine, if you like, rather than the discovery side, which I think is exciting from
yeah, we're missing tremendous data of what's going on at home, all the social determinants of health. We get just a fraction of that. And I think even within our own health system, right, you say, I want a listing of all the patients with heart failure with reduced ejection fraction. That is so incredibly difficult to do. You can't use the ICD-10 codes because they're all over the place. And so, AI can help greatly with that. And even assembling the databases, we've done some recent work in using the VA electronic health record data, and you can do a lot with, natural language and machine learning approaches that, exceed what we can do having a bunch of cardiologists doing manual chart reviews.
I had another question, just a quick follow-up, because you already highlighted therapy adherence. Another thing that I was wondering about that I think it's not talked about a lot is, do you also think that there would be large potential in optimizing operations, for example, in hospitals, like getting people to the right hospital at the right time, for example, but also like transferring people to the right ward at the right time and that sort of thing? Because I think that's often overlooked, especially when we only think about, for example, risk prediction.
Yeah, and what level of monitoring when a patient needs to be CCU versus lower care, the timing of discharges and the coordination of all the care that needs to be there, getting the right diagnostic tests done in the proper sequence and ordering. There's a lot of aspects of all of those things, the synchronization of the discharge to everything the patient needs at home, the coordination of care, social work, all of those aspects are right now, like so out of date, and it could be much better automated.
It's just simple scheduling of the nurses, or a patient cancels an echo, right, the day before, right? It's all manual work, right? It takes you ages, right, to reschedule all these holes in your schedule.
And I'll just add, in the United States, all this prior authorization that, it's a whole industry in of itself. That could be, automated, where all the documentation's provided meets criteria. It all happens automatically, and not getting on the, a trained clinician sitting on the phone for an hour to try and get a prior authorization advocating for their patient. None of that makes any sense from an efficiency standpoint or value basis.
Simple automation of the coding, as Gregg said, right? ICD coding, but also for reimbursement, right? These are right, not exciting things, but right, we spend a lot of time on these.
Thank you. I think this session has been really, really exciting overall. Thank you so much for everything you shared. And we would just like to give each of one the opportunity to give like one final statement, one key takeaway for the audience. Maybe Professor Fonarow, we start with you, and then go one by one.
Great. So, I agree this was a really dynamic discussion. Appreciated. I think we've highlighted some of the phenomenal ways that AI and machine learning can really fill many of these gaps that we have in cardiology and medicine in general. So really look forward to that. I think, I'll center back on this issue of adherence, that we could have just tremendous and phenomenal impact on the aspects of delivering the right care to the patient at the right time if we take advantage of these technological advances in a smart way that could really make a phenomenal difference in the outcomes of our patients.
Thanks. Professor Asselbergs, if you'd like.
Yeah, sure. No, it's a great session indeed. So I think, as we all said before, focus on the right automation, low-hanging fruit, logistics, right? The simple stuff, it's really important, and that's really something that's achievable in the short term.
Thank you. Mihaela, would you like to say a final thing?
Just want to thank tremendously to Gregg and Folkert, and I'm delighted, and it's music to my ear to what Folkert is saying, because this is very much what we are working on. And I also want to thank to Gregg, because he brought in this problem that I had before, but I didn't realize the importance of it, adherence. And I'll be thinking, and I hope other AI people who are listening to these sessions will be thinking about how to deal with adherence. And thank you both very much.
Yes, thank you very much. And with that, we would like to wrap up the session. Unfortunately, we will be having a summer break and see you back at Revolutionizing Healthcare in September. However, in the meantime, again, we strongly invite you to join our summer school to get you through the summer, but also to really get into the fundamentals of machine learning and AI, even if you have no prior experience. We will cover all important aspects. And it's going to be really great, and you're going to even have the ability to use AI tools hands-on. So thank you again for joining us today. We look forward to seeing you again in September. And thanks again to our amazing panel.